We're live. Okay, I'm going to wait exactly until 12 o'clock because I know some people are going to be trickling in. So bear with me. We'll give it another minute. 12 o'clock. All right. Hi, everyone. Thanks for joining me today. My name is Lauren. I'm a doctor of physical therapy. Excited to be with you guys chatting all things knee. I really enjoy treating the lower extremities, so I'm excited to be chatting with you a little bit about the knee today. But before we get going, and we'll let people kind of trickle in, I want to kind of get a sense of who is here so we can kind of tailor the conversation towards you all. So if you're comfortable with it, go ahead, drop in the comments where you guys are joining us from if you're comfortable with it. And then also your profession. If you're a physical therapist, an athletic trainer, a personal trainer, let me know so that, again, I can kind of tailor the conversation towards you all and make sure that it's a meaningful next few minutes that we get to share together. So I am currently, I'll start off. I'm currently in South Carolina. My husband and I have lived here for 3 years. He is a dentist for the Navy, so we're stationed out in South Carolina for a little bit. And we've got 1 more year here, and then we will be hopefully headed back west. And again, I'm a physical therapist. So let me know where you guys are from if you're comfortable with it. And again, your profession, and then otherwise we'll kind of jump into it as people keep trickling in. Hi guys. Canada, yes. Oh, physiotherapist and marathoner, love it. Personal trainer, cool. Awesome. Olympia from Ukraine. Wow, this is awesome. Such a good mix of people. Argentina, Portland, Oregon. My twin sister, also a physical therapist, she lived in Portland, Oregon for a while. So I've been to Portland many a time. Such a cool city. Minnesota, Germany, love it. Lots of personal trainers. That's awesome. Okay. UK, cool. Ireland. Man, you guys are joining from all over. Virginia, okay. Argentina. Okay. This is a good list. Vermont. I really, really, really want to go to Vermont. It's on my list of places to go. You guys have such beautiful falls there. I lived in Ohio for a little bit, so we kind of got a sense of their really pretty falls. But California, Hong Kong, sweet. All right. Cool. So I also want to make this very conversational as well. So as we go through kind of discussing the knee, please, please, please pop in with comments if you guys have certain questions. If I don't get to it while we're chatting about it, I will definitely try to address it at the end, or make sure that we get you the necessary resources to get your questions answered. Cool. Lots of Canada, India, triathletes, sweet. Okay, keep chiming in with where you guys are from and also things that you like to do, because that's awesome. I'm a big runner myself, and I treat a lot of runners and also a lot of triathletes. So kudos to you guys. Okay, all right, so let's get started. We're going to be talking about ACL today, patellar femoral pain, as well as patellar tendinopathy, MCL and LCL injuries, as well as meniscus type injuries. So I wanted to kind of tailor this towards the athletes. It seems like a lot of you all, yes, there's some PTs in here, but also some personal trainers, as well as athletes yourself. So again, pop in with comments that you have, whether that's regarding a specific client, a patient, or even yourself if you have a specific injury that you are dealing with. Cool. So let's jump in with ACLs first, because I know that's always kind of a hot topic in the space, right? So the ACL, the anterior cruciate ligament, its job is to prevent anterior translation of that shin bone on the femur. Okay. A lot of times we see ACL injuries with actually non-contact type of injuries. I think a lot of times in this space we think of, oh, an ACL injury is a contact type injury. Actually, no, about 70% of them are actually non-contact type of injuries. All right. So we see that more common than contact type of injuries, the femur actually rotates out and then that tibia rotates in. We call it internal rotation of that tibia. And then we can deal with an ACL injury. Sometimes we have associated MCL involvement as well as meniscus involvement, but we can't just have an ACL injury in isolation. That does happen. We want to think about too in regards to ACL injuries. We're learning a lot right now in this space about what we call a coper versus a non-coper. So when we think of a coper, this is someone who actually does not require surgery after an ACL injury. A non-coper is someone who does require surgery after an ACL injury. So how do we know if we're a coper? Well, right now research is telling us that there's actually a specific criteria that we need to have in order to be a coper and not require surgery. So a few of those things look like an ACL injury in isolation, right? So we can't have that MCL or meniscus involvement. We need to have a certain amount of strength and be able to perform a certain way on specific assessments and tests. And then we also need to be able to have a certain amount of quadricep strength at a certain amount of time. So just a few different things that we need to be able to present as if we are a coper. And then we also need to look at that level of activity that we're planning on getting back to, right? So we have different types of levels that we put certain sports in based off of the demands that it places on the knee joint as well as that ACL. So you also need to look at kind of your specific goals in regards to getting back to activity, whether that's skiing, running, snowboarding, whatnot. And if you are someone who is working with individuals with ACL injuries, or you have dealt with one in the past, make sure that you're having a conversation with the whole care team about what this looks like for you, whether you are a candidate to be a coper or you're a non-coper. Again, this is something that needs to be a multidisciplinary conversation with you and your care team. So yeah, looks like someone was a coper for 10 years before getting surgery. And this is something that we see as well. Some people are able to do just fine without surgery for a while, and then they do end up getting surgery down the road for X, Y, and Z. So again, just a conversation that needs to be had with you, your care team, and make sure that it makes the most sense for your specific lifestyle. Okay. That's always something that, again, is kind of hot in the topic of ACL. So I definitely want to address it. Another conversation that we're having a lot as physical therapists is, when do I get to return to sport? Okay. This is a huge conversation that we're always having with our clients and our patients. From the research, what we know is that you need to wait at least 9 months before returning to sport, at least 9 months. If you return to sports and performance prior to this, research shows that the chance of re-tear is actually 7 times increased if you do end up returning to sport prior to 9 months. So making sure that we are doing everything in our power to help make sure that our clients, our patients, again, you are prepared to return to sports at that 9 month. And then also make sure you guys, I feel like everyone has this like 9 month timeline, like, oh, I get to go back to sport at 9 months. Yes, for some people that's the case, but for others it's a little bit longer. So recognize that everyone's ACL journey is different, and that is very normal and very okay. And it's important to have those honest conversations with yourself and also your care team to make sure that you are setting realistic goals for yourself, and then your care team is also setting you up with realistic goals as well. So again, returning to sport and performance no sooner than 9 months, just to decrease that chance of re-tear. And then again, if that journey looks a little bit longer for you all past that 9 months, okay, totally fine. We just want to make sure that everyone is set up for success moving forward. So let me see. Does anyone have any questions? Okay, MCL after surgery related. Okay, we'll get to that. We're actually, we'll talk about MCL and rehab and all of that stuff. That's great. Anyone have any questions about returning to sport following an ACL, or any questions about the coper versus non-coper type situation that we just chatted about? Sweet. Okay. So last thing I want to get into when we're talking about ACL is making sure that we are doing the necessary assessments and tests to get you back to what we should be doing. So In the realm of PT, we have certain assessments and tests that we expect our athletes to be able to pass in order to feel comfortable getting them back into sport. Now, when I say getting back into sports, that does not mean that they are going from our clinic straight into a soccer match. No, that is graded exposure to them getting into practice. It's non-contact drills, then it's contact drills, and then slowly we're getting them back into sport and then performance. So something to really be mindful of is that it's not going from the clinic right into a soccer match or whatever that looks like for you. Again, it's still that graded exposure to get you back into performance. But it starts with being able to pass these certain assessments, as well as being able to demonstrate a certain amount of strength, especially through the quadricep muscle group. That's something that's really, really important in regards to ACL injuries, but also some of these other knee conditions that we're going to be discussing as well. So from a physical therapy standpoint, I want to show you all. So I'm going to present my screen here. Dun, 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 dun. Give me 2 seconds. It's going to take a minute. Okay. So I wanted to show you all just a few assessments that we do as physical therapists to make sure that everyone is ready to return to sport. So this is actually our prehab exercise library. It's a platform designed for clinicians that has over 3,000 exercises to design home exercise programs that are individualized for your clients and your patients. So I work with, like I said, I like training the lower extremity. I work with a lot of runners, triathletes, individuals who are dealing with knee-related injuries. So I've actually created what we call a template on the exercise library that has a group of ACL tests that I can actually send over to any of my clients if for some reason in a session we don't have time to perform these specific assessments. So I'm going to load it and it's going to pop up over here. So a few of the different assessments that we are looking at are what we call a crossover hop assessment. I like the single leg hop test for distance, so just seeing how far they can hop in that single leg position, and then the triple hop assessment as well. And then we always want to make sure that we're doing an agility test as well, just to make sure, again, that they're used to moving in a forward plane, but also we want to make sure that they're used to moving in a side-to-side plane as well. So if we click on, let's see, let's do the single leg triple hop assessment here. So these videos will populate and it's cool. So then my client can click on this. I will walk them through exactly how to perform the test, and then they can also read the description here as well, and it'll tell them how to perform the test. So when we're looking at performing these assessments, you guys, yes, we want to look at these type of assessments, the hop type assessments. They're really, really important for looking at deceleration and how our leg and knee track when we're in that landing position. Okay. But research is also telling us too that these type of assessments, yes, they look a little bit at quad control, but they're also really looking at ankle and hip control and strength as well, not so much at quad control. So current research is telling us that if we do want to really isolate that quad control, we need to be doing a better job of looking at vertical jump. Okay. So if you don't have a force plate or something in the clinic or access to a force plate, there's actually this really cool app called My Jump app that I've used several times. It's free, as long as I know it's still free, but it's called My Jump. And that's a really good way to be able to look at your vertical jump, and it helps you to get a better understanding of your quad strength and control, because again, that's extremely, extremely important when we're looking at return to sport and performance in regards to ACL, but also a lot of these other knee injuries. Okay. I'm going to, yeah, thanks, My Jump app. Cool. The ankle is so overlooked. Yes, I totally agree. The ankle is very overlooked, and also one of my favorite body parts to treat as well. And again, when we're looking at return to sport from ACL or any of these other injuries, we want to make sure that we are addressing the full body, right? Not just the knee, the ankle, the hip, the core, the thoracic spine, making sure that everything is moving appropriately to best support our return to play. All right. Let's keep on moving. I will get back to some of these questions. I just want to make sure that we kind of hit everything, and then we'll come back and answer some of the ACL specific questions. Okay, let's chat about patellar pain, patellar tendinopathy, patellofemoral pain, runner's knee, jumper's knee. There's kind of a whole gambit here. Let's start with patellar tendinopathy. So when we look at a tendinopathy, right, that is essentially irritation to the tendon from that tendon not being able to support the amount of load that we are placing it through. Okay, so we see patellar tendinopathies appear a lot in runners who increase their mileage really quickly. Think of those high school athletes who go straight into a jumping type sport, whether that's basketball, volleyball, those type of things. We can see patellar tendinopathies pop up on any type of sport where all of a sudden we're going from 0 to 100 in regards to loading that tendon in kind of a jumping or a running single leg type of exercise. Okay, when we look at management of tendinopathies, we really want to look at number one, load management, and then number two, we used to think that eccentric exercises or a negative, sometimes personal trainers will call those a negative type of exercises, were the way to go. But actually, research now is showing us that concentric and eccentric actually have very similar outcomes in regards to rehab for these tendinopathy type of injuries. It's really more about what we call progressive loading and then time under tension, right? So early on in rehab, we want to be able to introduce exercises that are going to load the tendon, but then also have lots of time under tension. So a really good exercise for that is what we call an isometric. So isometric exercises, especially for patellar tendinopathies, I really like a Spanish squat, and let me pull that up here in case you guys don't know what a Spanish squat is. I'm going to share my screen again. A Spanish squat is a great exercise to really load the quadricep muscle. So, oh man, I can't even spell. So Spanish squat, this guy right here. So it's a great exercise to really load the quadricep muscle because we want to work on really keeping an upright torso when we're doing so. This is going to decrease that hip hinge pattern and really place load through the quad. Okay. When we're looking at isometric loading of the patellar tendon, we want to shoot for, or any type of tendon really, we want to shoot for about 4 to 5 sets of about 45 seconds or so, giving about a minute and a half in between each rep. Okay. This is what has been proven to serve as more of an analgesic or a pain management type of exercise. So a lot of times I'll give the Spanish squat or even a wall sit, having someone lean up against the wall and then push through their toes to really get that quad engaged. I will give that as not a warm-up, but essentially a kind of a warm-up, an exercise that I want my runner to do or basketball player, whoever it is, prior to activity, because again, it can serve as that analgesic type of exercise. So it can be a good exercise to start with early on. Okay, Steve, I'm going to jump into your question about how to strengthen the quads. So lots of really, really, really great exercises for quad strengthening. I actually really like the knee extension machine. That's a really great exercise to strengthen the quad specifically because it does specifically isolate it. And I think a lot of times people kind of shy away from the knee extension machine because they've heard it's bad. We actually have a really great blog on, is the knee extension machine safe? And the answer is yes, it is. It's actually a great exercise to really isolate your quad. So that's a great exercise. Again, any exercise, I really like Bulgarian split squats. Those are a great exercise to isolate your quads if you're shifting your weight forward onto your toes more than pushing back on your heel. If you're back on your heel, you're going to get into a little bit more of that hip hinge pattern and use your glutes a bit more. If you shift your weight forward, you're going to encourage a little bit more of that knee over toe, which is very, very safe, but is a really good way to work on strengthening your quad. So something to progress into is something like a Bulgarian split squat, even things like a goblet squat with your heels up on a plate. So you're in a little bit of that wedge or heel elevated position is a good way to work your quads. So lots of really good quad exercises out there. And we have a lot of good blogs specifically looking at good exercises to strengthen the quad. So I definitely encourage you to check those out. Let's talk about Patellofemoral syndrome, because I know a lot of you guys are diving in with questions about that. And this is something that's also something that I get a lot of questions about from my patients. So Patellofemoral syndrome, a lot of times this is used as kind of a broader term for pain kind of in the front of our knee. Now, patellar tendinopathy is a little more specific. That's kind of palpable pain to the patellar tendon in the front of your knee. Patellofemoral syndrome is something that we kind of get that's a little bit of a broader type of definition for knee pain. A lot of times people think that their kneecap isn't tracking properly in the groove, and this is what is causing pain. Maybe someone's told you this before, but actually we're learning now with research that it's not necessarily a maltracking issue, and that there was actually a study done that showed that individuals whose kneecap tracked a little bit more laterally or out to the side actually had no increase in symptoms as compared to people whose kneecap didn't track as much to the outside, right? So regardless of how people's kneecaps were tracking, didn't necessarily mean that they were going to develop pain. So something to take into account there as well. What we do know in regards to managing patellofemoral pain is, again, we want to work early on pain management. So that's where isometrics can come into play, as well as regaining appropriate range of motion. If you feel like you're lacking range of motion, in both the hip, the ankle, and the knee. The ankle is something we really want to look at too in regards to how the knee joint is moving, because if we don't lack appropriate ankle mobility, that can affect how our knee is moving, how if the hip is moving up and down the chain. So you want to make sure that we're addressing all of those different areas. And then once we're able to manage pain, so again, early stages, range of motion, pain management, and then we want to start appropriately loading the knee joint. Again, one of the best ways to get our knees nice and strong is quad strengthening. So that's why I keep kind of hitting on quadricep strengthening, making sure that you're doing your due diligence to strengthen that muscle. With appropriate weight, we're loading that muscle up and making sure that we're getting it nice and strong. Let me see. I know there was another question about patellofemoral pain syndrome. Contraindicated exercises for patellofemoral syndrome. So I wouldn't say that there's anything that's specifically contraindicated. It's about, again, progressively loading so that that knee joint is able to tolerate the exercises that you want to put it through. So starting with isometric exercises, range of motion exercises to get healthy mobility in through the joint, as well as circulation and what we call synovial fluid, which helps to lubricate the joint. And then working on starting to really strengthen those supporting muscles, the quads, hamstrings, glutes, calf muscles, making sure the ankle is moving well, the hips moving well, we have good core stability, okay? But we're progressively loading and ramping up those exercises. This is something that we actually have a Patellofemoral program through our Rehab app that I think does a really, really good job of progressively loading you through the program to make sure that your knee is able to withstand the load that you're placing it through. So look into the Patellofemoral program as well. And then again, we have some really good resources on patellofemoral pain. We just had a great blog drop about busting myths around kneecap maltracking that touches on patellofemoral pain, and I would definitely look into checking that out. Hi, Andrew from Ohio. I just saw your comment. Okay, catching up. Okay, let me dive into, let's chat a little bit about MCL and LCL and meniscus. And then, like I said, I'll go through and answer some of these other questions as well. So let's start with MCL and LCL. So these are two ligaments, on the MCL being on the inside of the knee, the LCL being on the outside of the knee, right? A lot of times we can see these injuries to these ligaments in isolation, but oftentimes we can also see them with like an ACL injury or a meniscus injury. Now, if we are dealing with an MCL injury in isolation, this ligament actually gets pretty decent blood flow. So that means that it's in response to healing, it does pretty dang well with conservative treatments. So when individuals are dealing with an LCL injury or an MCL injury in isolation, again, that's the important part, in isolation, I really recommend conservative therapy to start, because these ligaments do get such good blood flow that it does help with healing, and typically people are able to get back to what they want to do with conservative management. Now, when we're looking at rehab for these specific type of injuries, we do want to make sure that we are, again, working on strengthening the muscles that surround that joint. Quadricep strength is super important. I don't know if you guys are picking up on a trend here, but quad strength is really, really important for these guys. And then again, hamstring strength, calf strength, glute strength. And the other thing that I think sometimes we shy away from because of how we sometimes get injured in these ligaments is doing lateral cutting type of movements, or what we call varus valgus type movements, letting the knee dive in, letting the knee dive out, right? These are not inherently bad movements and actually should be trained to get someone back to sport. It's just making sure that we're training them appropriately and safely, right? So if you have dealt with an MCL or an LCL injury, we want to make sure that at the end of your rehab, you're doing these cutting type of movements or these lateral type of movements to best load and train that tendon to be able to support those movements so you can get back to what you want to do. So I'm going to show you actually one of my favorite exercises for LCL and MCL injury. So these are specifically for MCL injuries. So the MCL, which sits on the inside of our knee, is going to help to control what we call valgus, or that knee diving in. And I really like this variation here. Lateral lunge. Let me see. Lateral lunge med ball. Okay, so this exercise right here is an exercise that I really like. As you can see, if you're dealing with an MCL injury on that knee here, that inside of the knee, practicing that deceleration, stepping out with that med ball and controlling that deceleration is a really good way to work on improving that ligament's load capacity. Okay. So that's one of my favorites. And we have so many good lateral lunge variations here. This is another favorite one of mine too. So you can see Craig's gonna step, throw the ball. So if we're working on, again, an MCL injury on that outside leg, as he steps and pushes off of it, that knee's going into that valgus type of moment. So we're training that ligament to be able to best support those demands that we're going to put it through with sports. And that's okay, but it should not be something that we shy away from training varus and valgus type movements in the knee. It's actually important to be training those. All right. Any questions about that at all? I just really want to touch on that because I feel like, again, sometimes that's overlooked when we're rehabbing from these specific injuries. Okay. And then last, let's touch on meniscus a little bit. So the meniscus, right, helps with force transmission. It sits between our shin bone and then our femur bone and is a little C-shaped pad that helps with force transmission up and down the chain. We can see meniscus injuries in isolation, but again, we also can see them with an ACL tear or with MCL involvement, depending on the mechanism of injury and the involvement of that injury. When we're looking at conservative management for meniscus, again, pretty good. This depends on a few things. It can depend on, your age, if you have other past history of injuries through the knee. It can also depend on where exactly the injury is within that meniscus. So the outer 1/3 of the meniscus actually gets pretty decent blood flow, while the inner 2/3 does not get as much blood flow. So if your involvement's on the outer 1/3, healing looks a lot better than in the inner 2/3. Not saying that you can't have really good outcomes with injuries to the inner 2/3 of your meniscus, but just something to keep in mind in regards to where that specific meniscus involvement is, and that's going to change a little bit too about your rehab and what that's going to look like for you in regards to timeline for tissue healing. But same thing with meniscus type stuff. We want to work early on range of motion management. A lot of times we see with individuals with meniscus involvement, especially if it's the backside, what we call the posterior horn, sometimes bending that knee or knee flexion can feel a little bit uncomfortable. So really working on regaining motion that's appropriate through that area, working on pain management so those isometrics can play a big role. And then again, we want to make sure that we're really strengthening all of those different muscles that support the knee. And then the other thing we want to work on too, depending on what that individual wants to get back to doing, is rotational stability through the knee. So a lot of times rotational movements through the knee when we're dealing with a meniscus injury can kind of be provocative. So if that's something that, said individual needs to get back to doing specifically for their sport or a specific activity of daily living, what we call an ADL, then this is something we want to train towards the end of treatment. But again, really focusing on that quad strength because that is one of the best ways that we can help to support a healthy knee joint. Okay. Any questions about meniscus or MCL, LCL right now? And then I will jump back in to answering some of your guys' questions. Do you have to take a break after 8 weeks? Is that after 8 weeks of working on meniscus, MCL? Provide me a little bit more context, Ricky. Um, oh, okay, Emma, I'm gonna jump into your question really quick. So Emma's asking, I'm quad dominant, so how do you strengthen your VMO? Really great question. The VMO, so the vastus medialis oblique, is a quad muscle. This is kind of a hot topic right now too. There are actually a lot of studies out there right now supporting that we can't actually isolate our VMO when we're working on quad strengthening exercises. And I know a lot of times, especially with like Patellofemoral stuff, sometimes people are like, oh, strengthen your VMO, strengthen your VMO. It's going to help to control your kneecap. Actually, it's really hard to isolate your VMO when we're working on quad specific work. So biggest thing you can do, Emma, is continue to work on your quad strength, not feeling like you need to really isolate your VMO, because it's actually really hard to do that. We have a really good blog about the truth behind your VMO. I would encourage you to check it out. Just type in the Rehab Guys VMO. It should pop up. And it's going to give you a little bit more insight into, can we actually isolate our VMO? Why can't we? And then some things to try that would definitely be beneficial. So check it out. Okay. 8 weeks of rehab. Ricky, I'm getting back to your question. So Ricky's asking, do you have to take a break after 8 weeks of rehab of strength training pertaining to patellofemoral pain syndrome? No, you don't have to take it. You don't have to take a break. Again, rehab is going to look a little bit different for everyone depending on the severity of your symptoms and when you get started with rehab based off of the severity of symptoms. So this can kind of vary person to person. But no, you don't have to take a break unless, symptoms are worsening or for some reason you need to take a break. But typically we recommend continuing with your rehab if you are able. So I think our Patellofemoral programs, I want to say, I can't remember off the top of my head. I have to check. But yeah, we encourage you to go longer than 8 weeks with your rehab if able. Okay, I'm going to go up to the top and answer a few more of these questions. And again, if I don't get to everyone's questions, I will be able to provide some context and different content that we have. Motor control evaluations for sprinters, knee injuries. Okay, I'm going all the way back up to the top. So we have a question about specific evaluations or assessments for sprinter knee injuries. So sprinter knee injuries are going to look a little bit different than your kind of distance runner injuries, but we still do see, like patellar tendinopathy type of symptoms as well. So it kind of depends on the athlete, what they're dealing with specifically. But a lot of times those single leg hop tests can reveal a lot about single leg control as well as motor control. I'd encourage you to look into those. There's a crossover hop test as well. There's a test that's the lateral step down test where one leg's up on an elevated surface and you're doing step downs just to look at strength of one quad compared to the other. Okay. So again, anything that's really going to look at our quad strength is going to be beneficial for sprinters, distance runners, runners in general. We want to make sure that quad strength side to side, especially if we've been dealing with the knee injury, looks pretty comparable. And the involved side should be within 90% of strength of the uninvolved side. So I hope that answers your question. Okay. Scrolling down. Okay. We answered some of those Patellofemoral ones. Sorry if I missed one. But okay, Spanish squat at a specific angle. So Jeremy's asking, do you perform a Spanish squat at a specific angle? So again, somewhat dependent on the individual and their symptoms. A lot of times if they're pretty symptomatic and they can't get down to about that 90 degrees of knee flexion, then you can start at about that 60 degrees or so. And this can help to decrease some symptoms if they're dealing with a lot of symptoms there. This is also a really good angle to also work the quads at as well. So kind of play around with those two different angles, kind of that 60 and then that 90, and see what feels best for you. And it may, involve you starting with a few at a little bit less of that angle and then progressing to that 90 degrees. But both of those are going to be good angles to, number one, get some healthy quad strength and recruitment, especially at that 60 degrees. And then number 2, to really work in an isometric range to get that quad and that analgesic type of effect. The big thing is when we're doing that Spanish squat, again, we're trying to keep that upright torso. So we're not hinging too much through the hips. That's, again, going to get our glutes involved a little bit more. If we can stay a little bit more upright, it's going to help to load our quads a little bit. Let's see. Okay. I wanted to make sure that was everything about the Spanish squat. About pain in the femoral tibial joint. All right. Jacob, I'm going to answer your question. What about pain at the femoral tibial joint? I get this when I run now and then and wonder why. So hard to say, unfortunately, without a thorough evaluation of why you may be dealing with this pain. Something that we definitely want to look at, especially for runners. Running is a single leg sport, right? So we are in that single leg position. We have that flight leg phase, and then we're in that single leg position again. So we want to make sure that we're looking at your control in that single leg position. Is it something, involving lack of mobility at the ankle joint that's affecting the knee? Is it a lack of strength somewhere up and down the chain that's leading to it? Is it lack of pelvic control? Hard to say, but we have a few different resources that I would look into. Check out our YouTube channel. We've got some really good running videos on there. Number one, there's a really good video on strength exercises for runners that I think you would find beneficial if you aren't incorporating some strengthening into your running routine. There's also a video on there about some tips and tricks that you can try in regards to your gait and see if possibly it's something with your gait that's going on. And then we also have a really good running prehab program through the Prehab app, which is specifically designed for runners to work on strengthening, mobility, and specific drills and stuff that we need as runners to help to stay injury free. So that would be another one that I would look into as well. But yeah, I wish I could answer that question a little more specifically, but I want you to check out those resources for me. All right, a few more minutes here. Okay, Earl, I'm going to jump into yours because you have a meniscus question. So Earl is asking about any sort of rehab tips for the week following his surgery. He's geared up for a knee scope for a torn meniscus coming up this week. Earl, we're all sending you lots of good vibes and healing on this next week and afterwards. Yes, so a few different things that you want to work on kind of that first week out. Number one, make sure you're listening to your care team. They're going to provide you with lots of insight in regards to what you can and can't do. Number two, we know that following the weight bearing precautions that are given by your care team is important. So make sure that you're asking, if you do have weight bearing precautions, what those are and what those are going to look like. And then number three, the sooner you can get into doing some early mobility per your guidelines and per your precautions is very important, because it's going to help to speed up tissue healing, get healthy blood flow in through the joints, help to get some of that inflammation under control. And then we do want to start working on some early muscle recruitment as tolerated. So again, it depends on how involved the meniscus injury is, what that surgery is going to look like specifically for you. But some early quad strengthening, hamstring strengthening, again, depending on what your meniscus surgery looks like, can be beneficial. So just making sure that you are having that conversation with your care team about what exercises can I do per my protocol, and then doing them as soon as you can tolerate them are very beneficial in you getting back to what you want to do sooner. But again, we're rooting for you. If you have any questions at all following your meniscus surgery, please, please, please reach out. We're here for you and would be happy to help to provide you with some further guidelines. Are you going to discuss squatting and deadlifting association with the knee? Frank, provide me with a little bit more content about what exactly you're wondering. Squatting is a great exercise to work on knee health, as well as glute health. It's just a really functional exercise, as well as deadlifting. I really like deadlifts. I think, again, they're a very good exercise to work on posterior chain recruitment. What I mean by that is, back strength, glute strength, hamstring strength, all of that stuff. So Frank, if you have, a little bit more clarification about what you mean by that, let me know. Okay. Can outcomes return to sport? Okay, Andrew, I'm going to jump into your question. Can outcome to return to sports activity be possible without meniscectomy? It's essentially a meniscus injury. Have heard PTs can give a similar outcome if given enough time. Yeah. So, like I touched on, Andrew, yes, there are many individuals who are able to get back to sport and performance if they have dealt with a meniscus injury. Again, this can depend on a few different things: the severity of the injury, where exactly it is, and then, your age, again, if you had any other injuries to the knee, degenerative changes, etc. But no, lots of people typically do pretty well with conservative care for a meniscus injury. Definitely a conversation to have with your care team if this is something that you're dealing with or a client or whatnot is dealing with. And then we have some really good resources for meniscus injury specifically. Through our prehab app, we have a meniscus rehab and a meniscus prehab program designed specifically for meniscus injury. So definitely something to check out there. Okay. Well, you're welcome for the kind words. You're gonna crush it. Okay. Any tips? Oh, okay. This will be okay. I'm gonna answer 2 more questions, and then again, if I don't get to everything else, we'll be able to provide you with some content. So, is taping and needling help with Patellofemoral syndrome together with quads exercises? Okay. So, yes, we get some solid questions about taping and needling for Patellofemoral pain syndrome. So, in regards to the needling, talking about dry needling specifically, and then taping is a technique that sometimes people use to help to control where the patella goes within the groove. So, research shows in regards to taping, yes and no. People do find that if they have tape on, sometimes they have less pain. Now, is this because it's actually controlling how that kneecaps moves in the groove, or is it more of just the individual knowing that they have tape on, and so that helps to give them a little bit more confidence and reassurance in that knee? Hard to say. There is some research that shows that specific taping using certain types of tape can help with kneecap maltracking or controlling that kneecap in the groove. Other types, not so much. Again, is this because it gives people a little bit more comfort? Hard to say. I have definitely had some patients who benefit from the taping, and if it gets them more comfortable with doing certain exercises so we can actually load up that quad, load up that tendon, whatever it is, then yeah, I'm going to toss some tape on them. But it's making sure that those individuals don't feel like they're reliant on that tape. So it may just be a tool for right now, but it's not a forever tool. Just something to think about and making sure we're having those conversations with clients and patients. Needling, same type of thing, depends on what exactly our goal is with the dry needling. So I do dry needling myself. Sometimes I find that if I can use the needles to decrease sensitivity of a specific area surrounding the knee, whether that's the IT band, maybe it's the quad, maybe it's the patellar tendon itself, whatever it is, then yes, there is a time and place for needling. But again, it should not be something that our clients and our patients are reliant on. We want to make sure that we're using it in conjunction with strengthening based exercises to get them the best outcomes for what they need to get back to. Good question. Let's see. Apple Runner. Any tips for runners with Ostrich Slaughterers? We have a really good blog on Ostrich Slaughterers. Definitely check it out. Type in the prehab guys or prehab and Ostrich Slaughterers. That's going to give you some good ideas. But with Ostrich Slaughterers, essentially what that is, if you're unaware, it's where the patellar tendon is pulling on the area of the bone of the shin bone where it inserts, and it can actually cause some discomfort of the area and some increased kind of calcification where that tendon comes down and attaches. So with Ostrich Slaughterers, we want to make sure we're really working on mobility of the quad if we are dealing with quad tightness. Isometrics can serve a role in regards to pain management early on, and then making sure that we're strengthening the appropriate muscles to best support the joint. We see Ostrich Slaughterers a lot in younger adolescents, especially boys, as they're growing. Those muscles are having a hard time keeping up with how quickly they're growing, and it can pull a little bit on that tendon, which can then pull on its insertion on the shin bone. So definitely check out that blog on Ostrich Slaughterers, and hopefully it gives you a few ideas. Okay, one more. Yes, check out the blog. Check out the blog. Let's see, where was it? I just lost it. Taping, needling. Okay, Emma, one more question. If you're a front chain loader, should you work on your posterior chain as a focus? Also, should you elevate your heels when squatting? Great question, Emma. So if you are front chain loader, or dominant means that you may be using your quads a little bit more, X, Y, and Z. Not necessarily a bad thing to have strong quads, right? As we've discussed during the last 40 minutes or so, quad strength is very important for healthy knees. But we also want to make sure that we're supporting those other muscles as well. Those muscles of the posterior chain, the glutes, the hamstrings, calf muscles, all of those need to also be working. So if you find that maybe you're a little bit more what we would call front train dominance, which it sounds like you're saying you may be, yeah, work on some of the posterior chain stuff. We're never going to get better from doing things that our body finds easy, right? So finding ways to challenge ourselves is a really good way to continue to get better, get stronger, find ways to keep our body fit, because we're not going to get better from doing things that are easy. So really, really good question. If you're elevating your heels while you're squatting, that is going to have you use your quads a little bit more. So just something to keep in mind. If you're wanting to bias your quads, put your heels up on a weight plate, a wedge, something like that. But if you're not wanting to bias your quads, use your heels down on the ground, shift that weight back, and get in that hip hinge to just work on that posterior chain a little bit more. Good question, Emma. Okay. And then last thing, I know I showed you guys a little bit of our exercise library, and we do have some personal trainers and PTs on here. So I just want to say that right now for National Athletic Training Month, we are running 30 days free access to our exercise library. The offer ends Sunday at 11:59 p.m. So if this is something you are interested in, please go ahead and comment National AT, and we will make sure that we get you the info to get signed up. Again, I love the library. I'm still a practicing clinician, and I use it all the time. It's incredibly user friendly, and I just think makes our jobs easier as healthcare providers. So if it's something you're interested in, want to explore, maybe you want to check out some of the assessments I showed you on there, some of the other exercises, again, comment National AT, and that's free 30-day access to our exercise library. Offer ends Sunday, so don't miss out because we never do this. Otherwise, you guys, great time chatting. If you have any other questions, please drop them in the comments now, and we will make sure that we provide you with resources to help you out. Otherwise, enjoy the rest of your Friday. Have a great weekend. Thanks for joining me all the way here in South Carolina from wherever you are. And also thank you too for following along on Prehab. We really appreciate you guys being here, taking the time to learn more about you, your body, and how you can best support those that you work with. Okay, we'll talk to you guys soon. Thanks. Bye.